You're standing in line at the grocery store, right?
Yeah, just a totally normal day.
Exactly. And the person in front of you suddenly just stops. They stare blankly at the chewing gum display, and they start repetitively smacking their lips.
Which is confusing if you don't know what you're looking at.
Right. I mean, they aren't ignoring you, and they aren't intoxicated. Their brain's electrical grid has just suffered this massive localized blackout,
Yeah.
and they are completely unconscious while standing upright.
It's honestly a terrifying level of vulnerability when when you realize how fragile our internal wiring actually is.
Oh, completely.
Because what looks like a deliberate social slight or just a strange behavioral quirk, it's actually a profound neurological event unfolding right in front of you in real time.
Well, welcome to this deep dive, everyone. Today, we're taking you on a journey into the most complex machine in the known universe, which is your own head. And it focuses entirely on intracranial regulation and seizure disorders.
It's a fantastic resource.
It really is. So our mission today is to demystify the biology of the brain's electrical grid. We want to uncover what happens when those circuits fail, how modern medicine attempts to rewire them, and what you should actually do.
And what you definitely shouldn't do.
Right, exactly. What you shouldn't do if you ever witness that system crash.
Because we live in a society that is incredibly quick to judge abnormal behavior.
Oh, for sure.
And when we understand the physical realities of the central nervous system, we can replace that fear and stigma with actual empathy and, well, actionable knowledge.
Yeah, the mechanics of a glitch are a lot less intimidating once you know how the machine operates.
Exactly.
So let's get into the machine itself then, because to understand a seizure, we really have to look at the central nervous system first.
Right, the brain and the spinal cord.
Yeah, which sits in that medial position, taking in all this sensory data from the peripheral nervous system and issuing instructions based on your past experiences.
It's basically the command center.
Right. But when we look at the clinical data on what actually triggers a system failure, it's a remarkably broad list.
It is. It's not what most people think.
No, we're not just talking about, the flashing strobe lights you see in movies. A seizure can be triggered by a high fever in a toddler, hypoglycemia, severe trauma, hypoxia, or even just an electrolyte imbalance.
Literally just being dehydrated or having your chemistry off.
Okay, let's unpack this. If a bad infection or just a drop in blood sugar can set this off, does that mean literally anyone's brain has the potential to short circuit under the exact right physiological stress?
Yes, absolutely.
Yeah.
Every single human brain has a seizure threshold.
Really? Everyone?
Everyone. Some people just have a really high threshold, and others, due to genetics or structural issues, have a much lower one.
Wow.
Okay. And what's fascinating here is that the underlying mechanism really comes down to cellular traffic control. The brain relies on billions of neurons communicating across synapses.
Right, the connections.
Yeah. Think of these synapses as intricate intersections, and they're governed by traffic lights. Under normal conditions, you have this perfect balance of chemical signals.
Okay, so how do the lights work?
Well, you have neurotransmitters like glutamate, which acts as the accelerator. That turns the lights green to send signals forward.
Glutamate is green. Got it.
Right. And then you have inhibitory transmitters, primarily GABA. And GABA acts as the brakes. It turns the lights red to stop the signal from spreading too far.
Okay, so a seizure is basically what happens when the brakes fail and the accelerators just get stuck to the floor.
Precisely.
Like every traffic light in the city turns green at the exact same millisecond.
It is a catastrophic failure of that chemical inhibition. An abnormal electrical impulse fires, and because those chemical brakes, the GABA, aren't working, that impulse just discharges chaotically across the network.
Because there's no red lights to stop it.
Exactly. A sudden drop in blood sugar or a massive spike in core body temperature changes the cellular environment just enough to disable those traffic lights.
Wow.
The neurons just begin to fire synchronously and uncontrollably at literally hundreds of times their normal rate.
Okay, so that explains the chemical failure. But the way this electrical storm unfolds in a person's life isn't just a sudden switch going from off to on, right?
No, not usually.
The source notes it happens in distinct chronological phases, starting with the prodromal phase, and this can begin hours or even days before the main event.
Yeah, it's a buildup.
A person might experience severe mood changes, insomnia, or intense anxiety. But my question is, how does a patient tell the difference between everyday stress, like just having a bad day at work, and the prodromal warning of a major neurological event?
Well, it requires an intense level of self-awareness
Yeah.
and pattern recognition.
Because symptoms are so vague.
Right. For someone without a seizure disorder, bad sleep is just bad sleep.
Hmm.
But for someone with epilepsy, which, by the way, is specifically defined as recurrent seizure activity.
Not just one seizure.
Exactly. For them, these subtle shifts are the earliest rumblings of the storm. They know the threshold is lowering, the chemistry is shifting.
I see.
And that prodromal buildup often culminates in the early ictal phase, which we more commonly call the aura.
The aura is absolutely fascinating. It's like the brain's internal weather app sending out a severe storm warning just seconds or minutes before the strike.
That is a great way to describe it.
The clinical presentation divides these into psychic or sensory warnings.
Mhm.
Psychic auras involve these really intense, complex emotional states,
Like what?
like a sudden flood of memories or an overwhelming, inexplicable sense of déjà vu.
And those psychological manifestations happen because the initial electrical misfire is originating in the parts of the temporal lobe that govern memory and emotion.
Oh, that makes perfect sense. It depends on where the glitch starts.
Exactly. If the short circuit starts in the visual cortex, the aura becomes sensory. The person might see flashing lights or experience blurred vision.
Right.
If it begins in the olfactory cortex, they might experience a phantom smell, like burning rubber or a strange metallic taste, even though the air is completely clear.
Knowing that the aura is actually the very beginning of the localized seizure makes so much sense. Like, it's not some magical premonition.
No, not at all.
It's literally the first intersection losing its traffic lights.
Exactly. And the practical application of this for the patient is massive. If you smell that phantom burning rubber, you know you have a window of time.
To get safe.
Right. You can get to the floor, seek privacy, and prepare yourself before the massive surge hits.
It's the difference between a controlled descent and a catastrophic fall.
Absolutely.
Right.
Because once the aura transitions into the full ictal phase, the main event, the conscious self is essentially locked out of the control room.
The storm takes over.
Yeah. The abnormal electrical activity takes over the motor functions, which often leads to a total loss of consciousness.
And then once the energy of that storm is finally spent, the brain enters the post-ictal phase.
The aftermath.
Right. The data describes this as a period of profound disorientation. The patient is super groggy, often complaining of intense muscle aches, and usually falls into a deep, unshakable sleep with complete amnesia of the event.
Just think about the metabolic toll here. The brain has just consumed an incredible amount of glucose and oxygen to fuel that uncontrolled electrical sprint.
It's basically running a marathon in a few minutes.
Yes, so the post-ictal phase isn't just tiredness. It is a forced physiological reboot. The neurons are totally exhausted, the chemical reservoirs are depleted, and the brain basically has to power down the higher cognitive functions just to perform basic maintenance and reset the grid.
Which brings us back to that grocery store scenario. Because the brain is so specialized, the electrical storm doesn't always look like a dramatic full-body collapse.
No, it really varies.
The clinical data draws a hard line between focal seizures, where the short circuit stays restricted to one specific neighborhood of the brain, and generalized seizures, where the surge spreads across both hemispheres simultaneously.
And those manifestations vary wildly depending on which neighborhood is experiencing the blackout.
Right.
The one that dominates popular culture is the generalized tonic-clonic seizure, which was formerly known as a grand mal.
That's the one most people picture.
Yeah, exactly. That's the sudden loss of consciousness followed by the tonic phase, a rigid stiffening of the entire body for about 10 to 20 seconds.
Okay.
Then comes the clonic phase, which is the rapid involuntary jerking of the extremities for another 30 to 40 seconds. It often involves excessive salivation, incontinence, and then that deep postictal sleep we just mentioned.
That's the presentation everyone expects to see, but the subtle ones are arguably way more complex to navigate in public.
Oh, absolutely.
Let's look at the absent seizure, which used to be called petit mal. It's most common in children and adolescents. It's literally just a sudden, vacant stare that lasts a few seconds. There's no warning aura, no postictal grogginess, and no memory of the lapse.
Fun.
All motor activity simply pauses, maybe with a slight twitch of the eyelids.
Now, just imagine being a teacher in a classroom and seeing a student space out like that.
Yeah.
It's incredibly easy to write it off as inattention or just daydreaming.
Oh, for sure.
You just think they aren't paying attention.
When in reality, the child's neurological grid is experiencing these micro crashes.
Wow.
And then you have psychomotor seizures, which are a type of focal seizure.
Okay.
The person remains partially conscious, But the electrical misfire forces them into bizarre, repetitive automatism.
Like the lip smacking we talked about.
Yeah.
Or they might start shivering or unbuttoning their shirt or seemingly hallucinating while wandering down an aisle.
Yeah.
They might appear heavily intoxicated or do something completely socially inappropriate, and they will have zero memory of it afterward. And if we connect this to the bigger picture, this is where that societal empathy becomes so critical. We're wired to react to unpredictable public behavior with suspicion or hostility.
True.
If someone suddenly falls completely flaccid to the ground, which is an akinetic seizure, or has a single forceful, violent body jerk without losing consciousness, a myoclonic seizure onlookers usually assume substance abuse or mental illness.
That's the default assumption. Yeah.
Recognizing these variations allows you to step back and realize, hey, I might be witnessing a medical crisis that requires compassion, not judgment.
So if a patient is experiencing these bizarre phantom smells or waking up on the floor with muscle aches, how do neurologists actually trace the origin of that specific short circuit?
It takes some serious detective work.
I bet. We transition into the diagnostic landscape here. They might use CT scans or MRIs to look for structural lesions like a tumor or physical trauma pressing on the brain.
Right, looking for the physical triggers.
And they use PET scans to look for metabolic abnormalities, but the primary tool is the EEG.
Yes, the electroencephalogram. It's really the only way to actually map the electrical grid in real time.
How does that work exactly?
By placing electrodes across the scalp, neurologists can basically watch the traffic lights. They are looking for specific, sharp wave spikes in the electrical current that pinpoint exactly where the abnormal firing originates.
Oh, so they can see the exact neighborhood.
Exactly. That precise mapping is what dictates the entire treatment plan.
And that treatment plan relies heavily on neuropharmacology. But here's what I find so perplexing about this section of the clinical data.
What's that?
It states that the primary medical goal is monotherapy managing the disorder with just one single drug.
Yes.
If someone's electrical grid is so unstable that they are regularly losing consciousness, why wouldn't neurologists throw a massive cocktail of every available drug at the problem to guarantee the circuits stay open?
That's a great question. To understand why monotherapy is basically the holy grail of seizure management, we have to look at how these drugs actually function at the cellular level.
Yeah.
Anti-seizure medications aren't curing a disease. They are altering the fundamental chemistry of the entire central nervous system to forcefully raise that seizure threshold.
They're artificially manipulating the traffic lights.
Exactly. But when you alter neurochemistry systemically, the collateral damage to the patient's daily life can be absolutely devastating.
Let's look at lamotrigine as an example from the source. The mechanism of action here is that it inhibits voltage-sensitive sodium channels.
Right.
So if a seizure requires a massive influx of sodium into the cell to trigger the electrical charge, lamotrigine essentially blocks the gate, preventing the signal from firing.
That's the goal.
But if you block sodium channels in the brain, you aren't just stopping seizures, you're blocking the pathways for normal, necessary signals too.
Which perfectly explains the toxic side effects. If you artificially suppress the electrical signals that tell your muscles how to move smoothly, you develop ataxia. Yeah, a severe loss of physical coordination and balance. Lamotrigine can also trigger severe dizziness, suicidal ideation, and a potentially fatal skin reaction called Stevens-Johnson syndrome.
Oh, wow. So the drug is keeping you conscious, but it's making it incredibly difficult to just navigate your physical environment.
Exactly.
The list of side effects for these medications reads like a nightmare. You have levetiracetam, which limits sodium ions across the cell membrane, but causes asthenia,
Which is an intense, crushing lack of physical energy.
along with severe non-psychotic behavioral changes.
Yeah.
And then there's topiramate. It works by increasing the activity of GABA.
And remember, GABA is our primary chemical brake pedal.
Right. So topiramate forces the brain to pump the brakes constantly. It stops the electrical surge, but because the brakes are always engaged, it leads to massive cognitive disorders.
Yeah, everything slows down.
Patients experience memory loss, confusion, and metabolic acidosis, where their blood actually becomes too acidic.
It's intense.
And if that wasn't enough, there's phenytoin, which can cause gingival hyperplasia, meaning the patient's gums literally overgrow their teeth, requiring intense, painful dental management.
And that is exactly why doctors refuse to stack these medications unless absolutely necessary.
I mean, I see why now.
If you give a patient topiramate to boost GABA and lamotrigine to block sodium, the compounding toxicity, the memory loss, the physical exhaustion, the organ strain, it just destroys their quality of life.
Yeah, the cure becomes worse than the disease.
Exactly. The clinical goal isn't just zero seizures. It is maximum seizure control with the absolute minimum toxic burden. The presentation explicitly notes that failure to take the prescribed medication is the #1 cause of treatment failure.
Well, yeah, because who wants to take a pill that makes them feel exhausted, confused, and uncoordinated every single day?
It highlights how intense the nursing and patient education side of this diagnosis really is. You are just handing someone a bottle of pills.
No, you are counseling them through a total lifestyle shift.
They have to strictly manage their sleep, avoid alcohol entirely, monitor their gums, navigate the loss of their driving privileges, and constantly balance their neurochemistry.
It is a profound psychological burden. A cure isn't possible for most. They are managing a chronic condition, trying to build a stable life while knowing that the grid could fail at literally any moment.
Which is exactly why the people around them, the public, need to know how to respond when it happens.
Let's bring this all down to the pavement then. The clinical presentation lays out the exact protocols for real-world intervention, both in a hospital and out in public.
Right.
In a clinical setting, a patient on seizure precautions has their bed in the lowest possible position. The side rails are padded and raised, and oxygen and suction equipment are hooked up and ready to go.
And notice the underlying philosophy of those hospital precautions.
Yes.
It is entirely about environmental management.
They aren't trying to stop it.
No. The nurses aren't physically restraining the patient. They're padding the environment so the patient's brain can ride out the storm without the body sustaining mechanical trauma.
That makes a lot of sense.
And that philosophy translates directly to what you should do if you witness a seizure in public.
The public protocol is incredibly specific. If someone goes into a tonic-clonic seizure in front of you, the first step is to assist them safely to the floor.
Don't try to catch them and hold them up.
Right, get them to the floor. You immediately clear the area of any harmful objects, move the chairs, push away the glass tables. You protect their head, ideally by placing something soft like a rolled-up jacket underneath it.
Yeah.
You loosen any constricting clothing around their neck, like a tie or a tight collar. But the absolute most critical physical intervention is turning the patient onto their side.
This raises an important point. The side-lying position is non-negotiable.
Why is that the most important part?
During the tonic and clonic phases, the patient has zero control over their swallowing reflexes, and they often salivate excessively or even vomit. If they are flat on their back, that fluid pools in the back of the throat, and they will aspirate it into their lungs.
Oh, which can be fatal.
Extremely dangerous. By rolling them onto their side, you are using gravity to keep their airway mechanically clear.
Gravity does the work. And you don't put a spoon or a wallet in their mouth. That is a dangerous myth that will only result in broken teeth or a blocked airway.
Please never put anything in their mouth.
And you never try to pin them down to stop the convulsions. You just let the electrical storm run its course.
Yes.
And importantly, you provide privacy. You shield them from the crowd and preserve their dignity during an incredibly vulnerable moment.
Exactly.
But here is the piece of clinical guidance that completely blew my mind because it contradicts every dramatic movie scene I've ever watched.
The ambulance protocol?
Yes. This pushes back against every dramatic movie trope I've ever seen. The presentation states explicitly that it is generally not necessary to send a patient to the hospital or dial 911 after a single typical tonic-clonic seizure.
It sounds wrong, doesn't it?
You mean to tell me that if I see someone drop and have a typical seizure, I shouldn't immediately scream and dial 911? You only escalate to emergency services if the seizure is unusually prolonged, if a second seizure immediately follows the first without them waking up, or if they sustain a massive physical injury when they fell.
Right.
That feels so counterintuitive. If I see someone drop and convulse, my instinct is to scream and call an ambulance immediately.
And that instinct comes from a good place, but it lacks clinical context. For a patient with known, diagnosed epilepsy, a standard seizure is an expected event.
It's normal for them.
Yes, it is terrifying for you to witness, but for their central nervous system, it is just Tuesday.
Wow.
The brain knows how to reset the grid. If you call an ambulance every time, you are saddling that patient with thousands of dollars in medical bills and a chaotic hospital visit for an event their body was already handling.
That's a really good point.
You only call for backup if the system fails to reboot.
That reframes the entire experience. It takes a moment of sheer panic and turns it into a moment of calm, managed care.
You aren't playing doctor. You are just managing the environment.
Protect the head. Protect the airway. Protect their dignity. time the event, and stay with them until they wake up from that post-ictal sleep.
Exactly.
This knowledge gives you the power to be a genuinely helpful, compassionate bystander instead of just a panicked onlooker.
It bridges the gap between clinical science and human connection. We've explored the cellular traffic lights, the bizarre sensory warnings of the aura, the intense trade-offs of neuropharmacology, and the physical mechanics of keeping an airway clear.
Yeah,
It's a comprehensive look at how resilient the human body really is in the face of chemical chaos.
it really is. We've mapped the grid from the inside out.
I want to leave you with one final thought, going back to the very first definition the source material provided.
Oh, about the central nervous system.
Yes, the central nervous system's primary function is to interpret incoming sensory information and issue instructions based on past experiences.
The brain maps its future instructions based on what it has experienced in the past.
Exactly that. So if our consciousness, our reactions, and our very personalities are built by mapping those past electrical pathways, what happens when those pathways are repeatedly subjected to the chaotic, unregulated electrical firestorms of chronic epilepsy?
Wow, I never thought about that.
It raises a profound question about neuroplasticity. A seizure isn't just a temporary physical glitch. It is a violent rewiring event. Understanding how a person maintains their cognitive map, their memories, and their sense of self through a lifetime of those storms is one of the greatest mysteries of human consciousness.
It's a testament to the sheer endurance of the mind. Think about that the next time you encounter someone acting a little out of the ordinary. And remember just how complex, fragile, and incredibly resilient the city grid inside your head truly is.